Now on to session 3. In this session, we discuss the so-called death of managed care. It's, as we shall see, slightly exaggerated. The rise of value-based payment as managed care took a beating, and more evidence on why Minnesota is a high-cost state. I begin with 2 statements by experts declaring that managed care was a mammoth failure. The first is from George Lundberg. He's a physician, and for many years, he was the editor of the Journal of the American Medical Association. And for many years, he was an enthusiastic proponent of managed care. He even co-authored articles with Paul Elwood. But sometime in the late 90s, he did a 180. And he said this to the Los Angeles Times in 2001. Managed care is basically over. People hate it, and it's no longer controlling costs. So if it's not saving money, then why should we have it? But like an unembalmed corpse decomposing, dismantling managed care is going to be very messy and very smelly. Take a while. God, I wish he would speak clearly. Unfortunately, the corpse was not buried. Managed care advocates put a new suit on it, put some lipstick on it, and trotted out value-based payment. This is another quote from another expert, Arthur Caplan. For years, he taught health policy at the University of Minnesota. I think he's at NYU now. And this is what he said to MSNBC also in 2001. He said, events of the past year, I don't know why he'd limit it to the past year, demonstrate beyond a doubt that managed care has failed and failed dismally. Now, we're going to discuss in the next few slides some of the evidence indicating that the managed care diagnosis was wrong and the solution was wrong. The diagnosis is wrong. Minnesota and US costs are not high because doctors order services patients don't need. We've got to get that through the heads of the agencies and legislators who might be sympathetic to more managed care. And the solutions were evidence-free, as we saw earlier. Congress and Minnesota policymakers endorsed managed care on the basis of no evidence. That's probably the most fundamental description of why we're in the healthcare mess we're in. Everything was done according to groupthink. Here's a slide containing an excerpt from a paper published in the Archives of Internal Medicine in 2013 by Deborah Korenstein and her colleagues. They looked at research over a 31-year period in peer-reviewed journals, not press releases from the HMOs, looking for evidence of overuse. They found very little. They said the robust evidence about overuse in the US is limited to a few services. Those services are mainly antibiotics for upper respiratory infection and 3 cardiovascular procedures. Carotid endarterectomy, which means it's a procedure to clean out plaque in the artery along the neck, coronary angiography, and bypass surgery. Now remember those 3 examples: carotid endarterectomy, coronary angiography, and bypass surgery. We'll come back to it in a minute. The diagnosis was wrong, blaming fee-for-service. And this is a simple statement from 2 experts in health affairs in 2001. They state, in fact, the direct association between fee-for-service payment and overuse has never been established. So these 2 statements ought to be the death knell for managed care if you're a sensible person. This study is saying there isn't a whole lot of overuse out there, at least non-documented. And this one is saying, and what overuse there is out there can't be blamed on fee-for-service. Whoops, looks like Elwood sold the wrong diagnosis to Congress, Minnesota legislature. By the early 2000s, you began to see some interest in the American health policy community in asking the question, is excessive quantity really the factor we should have been obsessed about these last 30 or 40 years? Or should we have been paying more attention to price? Well, Gerard Anderson at Johns Hopkins, Yuval Reinhardt at Princeton, and one other author published this article in 2003. I just threw my hands up for joy. Oh, yes, I'm finally getting some highly recognized health policy analysts to stop promoting the overuse diagnosis. And this is their title. It's not mine. It's the price is stupid. They say the US spends more on healthcare than any of the other OECD, means wealthy countries, spend, without providing more services than the other countries. This suggests that the difference in spending is mostly attributable to higher prices, and they say other research tells the same story. I'll give you one more out of several studies we could show you. This is from the British journal Lancet, 2014. Same conclusion. Prices rather than volumes of health services contribute the most to explaining higher US spending. The solution was not only wrong, evidence-free. It turns out that HMOs are no better at reducing the unnecessary services that do exist than doctors who are working for fee-for-service, that are not working for an HMO. This is research published in Medical Care 2013, and they looked at patients in Medicare HMOs, by that time it's called Medicare Advantage Program, and in the traditional Medicare program, often called the Medicare Fee-for-Service Program. And they looked at two of those services that we saw are often overused: carotid endarterectomy, coronary angiography, and bypass surgery. They looked at, what did I say? They looked at coronary angiography and carotid endarterectomy, and they found that the HMO docs and the fee-for-service docs were both producing overuse, 13% each in the case of angiography, a little over 8% each in the case of carotid endarterectomy. This is another more updated article, basically saying that the Medicare Advantage plans, all of whom practice managed care, were not able to reduce so-called low-value care any better than doctors in traditional Medicare. Now, as we'll see in session 4, don't want to trust pretty much anything, any of the research on low-value care, but be that as it may, turns out the insurance companies that practice managed care didn't beat the fee-for-service doctors in reducing so-called low-value care. And yet, the overuse due to fee-for-service diagnosis is still conventional wisdom, despite this mountain of evidence piling up saying it didn't work. Here's a quote from Roger Feldman, professor of economics at the University of Minnesota, 2015. A remarkable consensus has developed. I think what he really wanted to say was an unbelievably powerful groupthink has developed that the fee-for-service approach for paying medical providers must be replaced. This payment approach is said to increase the what? Volume of services. Now I turn to evidence that Minnesota is a high-cost state because our prices are high. We start with this excerpt from an article in the Star Tribune, 2016. They reported on a report that looked at 240 medical services, at the prices of them, and concluded that Minnesota has the 5th highest average price. The Minnesota Business Partnership represents a little over 100 Fortune 500 companies. They issued this report, their performance scorecard on Minnesota, in January 2015. They agree with what I'm saying. They said, overall, Minnesota spends more per capita, the national average ranking 36 in a 2009 study conducted by CMS. Now, if you recall what we said in an earlier session, that study is one of the studies that CMS releases every 5 years on state level spending. According to that study, Minnesota was much higher than the national average, and that's what you saw in the chart, in the graph that I showed you earlier. They went on to say that Minnesota performs near or worse than the national average in most of the available measures of unit costs. I think most people would say prices. And here's some examples. On the left side, you see some of the data the Minnesota Business Partnership published about hospitals, hospital costs. And over here, you see data on doctors. Over here on the hospital cost graph, you see Minnesota in the dark blue bar, US average in the light blue bar. And you see that no matter how you measure hospital prices on a per capita basis or per discharge, Minnesota's costs are much higher than the national average. That's in 2011. Over here, you see that Minnesota doctors are charging 39% more than the doctors in the rest of the country. Prices are a problem in Minnesota, and they account for our high costs. Business Partnership and the Department of Health also agree that the cost problem is not excessive use of medical services. Here you see the partnership stating in that 2015 report Minnesota's use of hospital services is pretty close to the national average. And interestingly enough, in 2003, the Minnesota Department of Health wrote, utilization of all medical services in the state is below the national median. What's the answer? Our prices are high. We do not consume more services than people in other states. Now I want to turn to the reaction of managed care advocates after their theology was so discredited in the late 90s and early 2000s. Rather than concede, yeah, managed care didn't work and we're really going to think hard about how we blew it, they went about inventing new language, value-based payment. You guys, if you wanted to, could create these graphs. There's a fun little tool available called the Google Ngram, N as in nobody. You just Google it, and up comes box, and you can put into that box up to 3 words. Well, so I put in the phrase managed care, and look what I got. Yeah, right here, after managed care tactics had spread so far, we needed a label. See, managed care emerges, enters the lexicon, and then it soars as the entire world jumps on the managed care bandwagon. And then, whoops, by 2000, everybody recognizes it's not saving money, it's irritating people, harming people, and its use began to decline rapidly. Now, the phrase is by no means extinct. It's just become much less popular. And so what happened in its place? Whenever your cereal gets a battered reputation, you give it a new name. That's what happens in health policy. Managed care advocates invented value-based payment. You can think of value-based payment as basically warmed over managed care. It isn't that different from the managed care ideology we've been discussing so far. The 3 tools that managed care refers to are financial incentives to induce doctors to deny services, micromanagement of doctors, quality measures and prior authorization, and limited choice of provider. I've put the limited choice tool in blue because that's the main difference between the old managed care Kool-Aid and the value-based payment Kool-Aid. Value-based payment was invented in the 2000s, mainly to describe accountable care organizations, but there are a couple of other iterations of value-based payment that I don't have time to talk about. The main difference between HMOs and ACOs is that the ACOs do not try to limit the patient's choice of provider. Why? Because you don't know you're in an ACO, strangely enough. But ACOs use the other tools, financial incentives and micromanagement of doctors. The Accountable Care Organization is the largest and most widespread value-based payment scheme. It was invented in 2006 by the Medicare Payment Advisory Commission, and MedPAC recommended it to Congress in 2009, just as Democrats were starting to write the Affordable Care Act. Democrats swallowed the bait and they inserted into traditional Medicare via the Affordable Care Act, ACOs. Once CMS started setting up ACOs, it began around 2012. Private sector followed suit. Today, there are about 1,800 ACOs in Medicare, Medicaid, and the private sector. Another difference between HMOs and PPOs on the one hand, ACOs is members are assigned, they don't know they're being assigned, and they're assigned to an ACO based on the plurality of visit rule. I'll just give an example. If Don is my primary care doctor in 2023 and I see him twice, and I see Sandra, my other primary care doctor, once, then in 2024, I'll be assigned to Don, and if Don is in an ACO, I get swept into his ACO. If he's not in an ACO, I don't get swept into an ACO, even if Sandra is in an ACO. I want to go quickly through these slides because all I want you to really understand is the ACO is very hard to define. You don't know what it's supposed to do. And for that reason, it's very hard to hold these people accountable. Here's the definition from the Medicare Payment Advisory Commission in their June 2009 report. They said the defining characteristic of the ACOs is that a set, or what? All physicians, all hospitals, 12, 20, who knows? A set. Physicians and hospitals accept joint responsibility. Well, from whom? And how are we measuring the responsibility was met? Don't ask. They accept joint responsibility for the quality of care, cost of care received by the ACO's panels of patients, their unsuspecting assignees. The goal is to create an incentive for providers in the ACO to constrain what? Volume, while improving the quality of care. If the ACO achieves both cost and quality targets, and these are sloppy targets, its members, i.e. the docs, receive a bonus, and if they fail, they get penalized. What does that sound like? It sounds like HMOs. I just want to warn you of the some of the manipulative jargon you're going to encounter. Value over volume is the new mantra of the value-based payment advocates. And I just show you here an excerpt from an evaluation of one of the ACO experiments that CMS launched in 2016. Even the evaluators say, well, the purpose of the ACO is to promote value over volume. And we're all supposed to go, oh yeah, I know what you're talking about. And I know how that's supposed to happen. Consultants hired by CMS have a hard time evaluating ACOs because they can't define it. Here's a quote from one of the evaluators. Demonstration was not designed to test specific interventions. Evaluations of interventions could not be done. This is a somewhat humorous remark from a MedPAC commissioner. They were meeting in November 2013, trying to figure out how to talk about ACOs. This commissioner, Jack Hoadley, said, I think even a lot of smart people have trouble explaining to somebody, maybe their own parent, what this is. So I say all this because if you have a hard time understanding what they are, it isn't you. It's this goofball, manipulative language that makes it really difficult for anybody to know what they're talking about. Here is the single best definition of an ACO I have ever seen. HMOs in drag. The person who came up with that was Kelly Devers. She's a senior fellow at the nonprofit Urban Institute. And in an interview with Kaiser Health News. And interestingly, the reporter for Kaiser Health News bothered to ask the all-important question. Could it be we're doing the same thing over and over and expecting different results? This should be shouted from the rooftop. We're just trying to do the same thing over and over and expecting different results. That's the definition of insanity. Very briefly, MedPAC says ACOs do not improve quality. Here's a quote from an article I wrote with Jim Kahn for the Journal of General Internal Medicine in 2021. We looked at the various ACO programs that CMS had started since 2012, and we found that they roughly broke even from the CMS perspective. That is, when bonuses CMS paid to ACOs are subtracted from gross savings, programs lost money or saved no more than a few tenths of a percent. And we noted in the article this is probably a generous conclusion. Some of the studies that say they broke even were biased in the ACO's favor. The last thing to be irritated about with ACOs is they worsen consolidation, as if it weren't bad enough already. Here's a report for 2019. Found a clear association between physician consolidation and county level ACO presentation. To sum up session 3, managed care clearly failed by 2000. Advocates invented value-based payment to replace it. Value-based payment is warmed over managed care. It's basically the same diagnosis and a very similar solution, financial incentives and micromanagement. The ACO is the leading example of a value-based payment scheme. It's invented to reduce what? Overuse. But it's so vaguely defined, even experts can't say how it's supposed to do that. Evidence indicates ACOs neither improve quality nor lower costs.
Thank you for watching this video. See the description below for links to the primary sources used during this training. Healthcare for All Minnesota has more videos and looks forward to you joining our efforts.